Welcome to the podcast on assessment and management of cancer related to older adults with complex care needs. This podcast was created by Melissa Aslagi at the University of North Carolina at Wilmington. It's based on content authored by Janine Overcash.
Hello, my name is Janine Overcash, and I'm an assistant professor at the University of South Florida in Tampa, and I specialize in geriatric oncology, and I like to look at the functional status of older cancer patients. So some of the learner objectives specific to this content are to help faculty provide a realistic vision of the older cancer patient, the needs patients have with pre-existing conditions, the needs patients have with supportive care concerns such as caregivers, issues of things such as nausea associated with treatment, fatigue, anemia. All of these pieces have to be presented to students so that they know how to anticipate some of these common concerns and can certainly intervene upon them. I think one of the biggest things as faculty that we can transmit to our students is that older cancer patients are very active. They're busy, they're typically volunteering, they live in the community, they're into their 70s, and that cancer is one of many comorbid conditions that have to be treated, along with blood pressure and arthritis, diabetes, all sorts of things that tend to pop up as we age. Now, cancer, while there are many treatments for cancer, cancer can be in early stages of treatment where surgery and hormonal therapy meet the needs of the patient. People can be faced with more aggressive needs. So we have to draw those issues to the undergraduate learner. Now, we have to be careful because you can get so far in depth with different cancer protocols, with the NCCN guidelines, that we would lose the typical undergraduate student. I think that when we talk about supportive care, cancer care to undergraduates, we have to be very clear that we're talking about supportive care nursing needs. All of the other issues, such as the clinical protocols, will be identified when they get into that specific site. I think it's very important to bring the realistic vision of an oncology patient to the undergraduate nursing student. And it is very important, just because somebody's in their 70s or 80s doesn't mean that they should forego treatment. Issues such as functional status comes into play when you're considering what sort of treatment somebody can undergo for curative care. Somebody in their 70s may be very fit with low comorbidity, high functional status, very independent, and it can endure any sort of cancer treatment that a 50 or 40-year-old could endure. And so it's important that nurses advocate for seniors in treatment care realms of oncology, as well as know how to care for the patient on an inpatient level as well as an outpatient level. Aging is a risk factor for cancer. So we have to think about who is the core consumer of oncology services, and that's people 65 and over. So that the typical cancer patient is older, and that we need to consider not only the diagnosis of cancer, but issues of comorbidity as well as independence and living situation. It's critical that nurses and other healthcare providers have specific knowledge required to care for the older cancer patient, and that's what drives the essence of this lecture. Comorbidities and geriatric syndromes are critical to identify upon initial nursing assessment of the patient before treatment ever begins for cancer. Issues of emotional status, a depression screening is very important. People who screen for depression or are treated for depression tend to participate less in cancer screening and treatment activities. So it's important that we identify these issues and certainly treat them. Issues of caregiver support. If someone doesn't have a ride to come to cancer treatment, they're unlikely to show up. So these have to be identified so that possible plans can be put in place to facilitate enhanced treatment. We talked a little bit earlier about comorbidity. I can't stress how important it is that issues of hypertension, diabetes, all of that have to be treated and cared for, just as the cancer diagnosis has to be treated and cared for. A lot of times patients are so afraid of a diagnosis of cancer that often they let issues of cardiac status or respiratory or anything else go in the notion that cancer is the most lethal? Well, I think we have to make sure our students remember that more people die of cardiac issues than they do of cancer. So it's important to stabilize those comorbidity. The other pearl that I'd like to pass on is that we have to identify with our patients, is this patient going to die of cancer or with cancer? If someone is going to die of cancer and that the cancer is most aggressive, perhaps the treatment plan changes more to focus toward the cancer. But if cancer is one of many comorbidity, it is just that, one of the many angles of a treatment plan that have to be developed.
So here in your example where you're talking about joint pain in an older adult diagnosed with breast cancer,
you have to differentiate upon your assessment. Is this pain a joint pain or is it pain from a metastatic process?
So how is care different for a frail older adult when dealing with cancer?
Well, it's important for undergraduate nurses to know how pivotal a nursing assessment is when seeing an oncology patient. If someone presents to the clinic for initial treatment of a malignancy, who perhaps is more frail, perhaps over the age of 85, has functional dependence issues, has geriatric syndromes, has uncontrolled comorbidity, and requires reasonable assistance, a care plan has to be developed to manage both the cancer as well as the supportive care needs of the older person. Frailty is defined in many ways. Fried et al. At Johns Hopkins defined frailty as a series of physical benchmarks, such as weight loss equal or less than 10 pounds in 1 year, weakness as measured by grip strength, self-reported poor stamina and exhaustion, inability to walk a great distance, and as well as a reported low physical activity level. These create the picture of the more frail older adult. Now, we have to be careful. Just because someone's frail doesn't mean they do not get any oncology care. You may have a very aggressive tumor on a frail patient that needs to be dealt with so that they can maintain the level of life that they are living. It's important to consider issues of pain control as well as symptom management in people who are less well and are oncology patients. Now, what has to also be considered is that if somebody presents to the provider that are not frail and are becoming frail as a result of their cancer, as a result of treatment, that's when an acute assessment has to be performed so that we can figure out why that frailty is occurring. Is it a reaction to the cancer treatment? Is it tumor progression? Is it frailty that can be reversed? All of these are possible. Just because somebody is appearing frail doesn't mean that no further assessment and treatment should take place. It's when it's most important for the assessment and treatment to take place. The comprehensive geriatric assessment fits very well with the older cancer patient in that you're looking for things outside of the routine history and physical. You're looking for things such as emotional status and specifically screening for it, issues of cognitive limitations or dementia, issues of gait, functional status, grip strength. All of these can be assessed in addition to the regular history and physical exam and do not actually take a lot of time. Resources such as the Try This series, which are online, can be adapted into the oncology inpatient and outpatient setting. So it's important that before patients undergo treatment for cancer that we get a baseline, and it can be obtained using comprehensive assessment. No two assessments are alike. For one patient who may have particular needs, their assessment may look different than someone else's assessment. The issue is the nurse must recognize what limitations are most foremost for that patient, screen, obtain a score or a level, and rescreen as the patient comes back to understand, are these things getting better or worse? Do we need to adapt the treatment plan? Do we need to formulate a new treatment plan? And keep eyes on the patient in this more acute manner.
So why is considering an older adult's functional status important with this population?
Functional status, more so than chronological age, is critical in the plan to developing a cancer management strategy. A 74-year-old who has had a fractured hip, is not walking, is fully dependent, is a different clinical picture than a 74-year-old that is perhaps working, walking 2 miles a day. So those clinical pictures look different. It is functional status, not age, that has a lot to do with treatment accommodation. Now, functional status can be measured in several ways. There are the standards of functional status assessment, which is a self-report measure of activities of daily living, as well as the instrumental activities of daily living that look at more fine, independent issues such as driving, fixing meals, going shopping. Those things are very important. I'm learning through our research that perhaps performance status measures are more robust assessments of functional status than the self-report measures. Issues such as measurement with the timed up and go give you more detail into how a person functions at home when they're away from the clinic than do self-report measures. And I think it's important to look at some more functional performance measures than self-report measures as we do these assessments. Many of us over-report our capabilities. It's not a uncommon thing. I think when we can see unsteady gait, when we can see somebody unsteady getting out of a chair, as clinicians, we know there's more problems at home. There's more problems getting around. The other issue is functional status decline in older cancer patients is so related to falls. And falls are the big problem in many cancer patients treated with chemotherapy. We found that a rate of 21% of falls were reported in people with cancer not receiving chemotherapy. When you threw chemotherapy in the mix, that percentage went up to like 32%. So something about chemotherapy enhances the risk of falls. You throw functional status problems into that, and there is a very large risk. 21% of people who fall and go to the hospital do not come out. There is a very high mortality rate. So these are very large issues that we have to anticipate and try to prevent as we establish the nursing care of the older cancer patient.
When an older adult with cancer falls, and there is this increased morbidity and mortality associated with those falls, how do you define a fall?
Let's define a fall, and let's talk about why it's important patients don't fall. And a lot of people have defined a fall. You would think of the notion of a fall as intuitive. You trip and you fall down. What happened? How far do you fall down for it to be a fall? Well, the Kellogg Foundation has defined falls, and that is unintentionally dropping to a lower level than you were previously that is not a result of some pathology such as a seizure or fainting or something like that. That is considered a fall. Now, the issue with falls are that falls can inspire injury, and injury can lead to treatment delays or treatment dose reductions. So that's why it's so important to think about talking to patients regarding falls so that these treatment reductions or these delays do not encumber your survival of this tumor.
For a nursing student or a practicing nurse, what are some resources to help screen older patients for fall risk?
The biggest issue of fall screening is to ask somebody, have you had a fall in the last year? And that's the American Geriatric Society standard at this time. It was developed in 2001 and is still really the standard of care today. Have you had a fall in the last year? Tell me what issues surround the fall. Have you fallen since? Are you fearful of falling? These are questions to ask. There are some fall risk screens, but it's important, especially for the cancer patient, to really sit down and do an interview with the patient concerning the fall. You know, a history of the fall is the biggest risk factor for encountering another fall. And so you want to determine that. Now, can we prevent falls as nurses? Well, the answer is probably no. People fall for a cadre of reasons, many of which we can't prevent, but we can have the discussion about what to do when the patient falls. If you're prone to falling, have a phone somewhere at a lower level that can be reached. When you go into the bathroom, take a phone. Do not lock the door when you go into the bathroom. Perhaps you need the life alert system of should a fall occur. Should you notify somebody when you're going into the bathroom? Because the bathroom is the place where people tend to fall the most. So these issues are important for discussion, for proactive discussion, because again, I'm not sure we're going to prevent the fall. We may reduce the probability of injury, however, when we talk about some of these precautions. Thinking and talking about health promotion and cancer screening, when does the older person stop electing to get screened for cancer? And this is a very foggy area. No age limit is essentially defined. It is more about frailty. If somebody at age 75, 85 has so much frailty that cancer screening is not going to perhaps increase longevity, then it's important to elect not to do the screening. But if somebody is interested in living for 7 more years, or who's 82 and wants to live 7 more years, perhaps considering basic screening may be appropriate. Now, screening is fairly available in most areas, especially with mammography, mobile trucks and things, but seniors who do not have transportation tend to do less screening. So that becomes important when you're doing a nursing assessment or a discharge planning summary about health promotion, that these issues are taken into consideration.
So are there certain segments of the population that are more vulnerable to not having access to screening or not participating with the screening?
There are disparities in screening in the United States. I think that research and various groups are making strides in delivering care to everyone. However, I think the battle goes on to make sure that there are adequate services in all aspects of all communities. There are 2 questions to note when considering cancer screening in the older person. 1, is this older person going to die of the cancer or with the cancer? And 2, can this patient tolerate cancer chemotherapy?
So when we're thinking about doing assessment of older adults with cancer patients, what are some of the issues that we should probably consider?
Well, it's important to know some tendencies of treatment, cancer treatment. One is older patients tend to present later for assessment of their disease. Sometimes people think, oh, that pain is just related to aging, I'm just a little slower, I just feel a little more fatigued. And those sorts of things can mask signs and symptoms of a pending malignancy or a malignancy that is occurring. The other issue is older people tend to have a lot of healthcare providers. And so one healthcare provider may very legitimately think another one is dealing with whatever problem, and it sort of gets dismissed thinking that, everyone is taking care of it. And that is also very common.
So it may be important to encourage a primary care provider for any older adult that you're seeing.
That's right, and not, encourage the primary care provider to take the lead in oncology screening and to screen according to the standards of care. And the other issue is to empower the patient. As nurses, we should empower the patient to be able to say to them, you need these screenings each year, and, it's up to you to ask whatever physician it is to order these screenings and to follow up on the results, and that's a very big issue. A lot of times we have people that endure the screening but do not get the results, so that picture has to be fully developed from screening to results when patients undergo that. Again, it's so important to talk about limited social support. People will tell you they have plenty of support, and they get phone calls all day long. Well, you need more than phone calls in many cases to be able to support an older person that's undergoing chemotherapy. You need a present caregiver. And it's important to ask those words, do you have someone at home should you not feel well and need someone to fix dinner or to care for you? And it's important that becomes highlighted in the care plan. One thing that you would think we do not have anymore is ageisms. And ageisms do exist. I think a lot of times from my oncology practice, we see patients that haven't had screening because they're in their 70s. And honestly, that shouldn't be. I think we have to dispel some of the notions, both from a provider level as well from a patient level of screening and cancer care, perhaps not so based on age. We have to consider that comorbidities may also mask some of the signs and symptoms of cancer. Issues such as degenerative joint disease that may be associated with a bone pain may have more to do with pain than a malignancy, but it has to be certainly discerned.
So what we've provided today is really just the basic introduction to considerations within cancer treatment and assessment and screening, but the actual symptom management during chemotherapy is a whole nother realm of or oncology, nursing, that if
Absolutely. There are available, well-done online resources to enhance the assessment of the older cancer person. The first one has to do with the Try This series. I mean, that's important. There are so many assessment screening tools that are germane to the older cancer patient, from problems with sleep, issues of sexual intimacy, pain, polypharmacy, very common problems associated with older cancer patients. Now, one thing I think it's important to stress, screening is the easy part of the care plan. What are you going to do about what you find? That becomes more complicated. When you reveal limitations that may have to do with sleep or with sexual intimacy, you must have a plan, a proactive plan in place that are going to help resolve some of these found problems. So be clear. When you screen, make sure that it's what you're screening for is in the realm of what you can intervene upon. And that is an important issue. The second piece is when we screen in oncology, you've got to make those results known to the rest of the care community caring for that patient. You have to call other physicians, send your dictations to those offices so that everybody's on board. Hey, we've done this screening, here's what we found, here's what we've done, we just want to keep you abreast. Because again, care gets very complicated when multiple partners, care partners are involved, and especially from an oncology perspective, we have to involve everyone in the results of these screening tools.
So the role of nursing after the older adult has been through the screening and the actual diagnosis is going to be, again, going back to the objectives of the podcast, to help manage the supportive care, to act as a collaborator and a coordinator of care, and to really serve as a source of information for patients and families as they kind of go down this path of oncology treatment or not, depending on what their individual goals are.
That's precisely right. And I think the nurse is the catalyst to pull all of those pieces in and make this care effective.
So in conclusion, any final thoughts, Dr. Overcash, for baccalaureate nursing students?
In summary, I am passionate about the needs of the older cancer patient. And I think that students should be inspired to know that the field of oncology is a wonderful field, open with so many opportunities, and the core essence of that field is geriatrics. So that if you're interested in breast cancer or prostate cancer, you're really going to be dealing with people 65 and older for most of your patients. And so I think it's important to appreciate that fact and to think about ways in which we can help motivate better care for older cancer patients.
I would like to thank Dr. Janine Overcash for being with us today and for sharing her thoughts on some of the considerations that baccalaureate nursing students need to keep in mind when caring for older adults with cancer.